presentation. Kahoot is going to help us along with this. So you can join the interactive portion a couple different ways. One, you can just scan the QR code up on the top right, and it will take you to a screen where you just kind of make your own nickname, whatever you want it to be, and you can join in, or you can go to kahoot.it, and then it will take you to the same place. So you can also make your own nickname to join. We've got toe, love it. Cute little icons. And your nickname doesn't really matter what it is, as long as you know what it is and you can keep track. So this will, after every question, it's going to kind of give us answers of who got it right. And just to let you know, we're playing for points, and there is a winner today. So I have one prize for whoever is the grand champion today. And the sooner you answer the questions, the more points you get. So just kind of keep that in mind as we're trying to answer. So not only correct answers, but the timing of your answer matters too. Danielle is here, I can see. Shakalak. So we can kind of start talking as everybody's joining here. Our this is meant to kind of give everybody a better understanding of corneal ulcers today. So I know that there is, a lot of variety and of different severity of ulcers and different treatments. So I'm going to I kind of plan this to be more engaging for everybody, so you can kind of help you to get a better understanding of all of that by not only looking at these ulcers and kind of giving your own opinion, and then giving
be able to hear sound for everybody.
Choosing medications to use, and just kind of trying to broaden the understanding of ulcers. It's actually not letting me advance. I'm gonna go ahead and start the Kahoot, but people can continue to join. Uh-oh. So as people join, they can go to kahoot.it and then use the PIN number there along the bottom. So Caroline, I don't know if there's more people that join, if you can maybe direct them if they're having some questions, but hopefully everybody can get there. So here's a nice gnarly picture of a corneal ulcer to get us started. We've got 25 people. Wow, people are still entering, so maybe we should just wait a minute.
And for those joining with some generic names for like their phone or their computer, I'm just sending you a separate chat message if you can reply with your first and last name for attendance, and then I can get you checked off.
All right, we're gonna go ahead and get started. It sounds like there's not been a lot of people entering for a second.
Hey, Caroline.
Yes.
Can you guys let Allie's like sitting in the waiting room? It won't let her in. I don't know if that's whoever's in charge of that.
I don't have anyone there. Let me reopen it real quick.
It says she's sitting in the waiting room.
Go.
Thank you.
What happened?
Yeah, no problem. Sorry, I had to reload it.
So I should restart. Well, all right, we're just going to keep going. So that picture, so I was asking what area of the eye do you apply fluorescein stain to? I think that was a little tricky now that I'm looking at how the answers came up here, but the purpose of that was that I don't want you to apply corneal stain directly onto the cornea, because essentially that fluorescein strip is a piece of paper and you can cause like a false corneal ulcer. You can actually give them a little paper cut on their cornea if you were to touch it directly onto the eye. So the purpose of this question was to try and have you, instead of directly applying it onto the cornea, would be to apply it onto another part of the eye. So you could apply it onto the conjunctiva up above the eye, let the fluorescein down on the cornea. Alternatively, you could put it on the third eyelid. Ideally, you wouldn't be putting it onto areas of the eye, like outside of the eye, because we don't want to rinse any of that bacteria onto the corneal surface.
I'll get it.
Ideally, here
Okay, that's all right. Just center yourself.
Hey guys, let's be sure to mute ourselves just because there's a little bit of interference over Dr. Zimmer's presentation.
I think it might have been Amy. I don't know if she has a question. If she does, maybe she can type it. But so do not apply the corneal stain directly onto the cornea, rather go onto the conjunctiva so that it can get to where it needs to go. We had our scoring here. E came in first here at 937. So you can kind of see the rest here of the leaders of the scoreboard. Hopefully everybody has gotten in and can successfully do that. Is there a message? Oh, all right, Caroline can handle that. All right, we will continue. So just a reminder, when we're doing the fluorescein stain, that it's important after you put it on, blink the eye, rinse the cornea off, and then go into a dark room and use that cobalt blue light to really evaluate if there's fluorescein stain. I think that a lot of people, especially in emergency situations where, you know, we're in a well-lit room, and when we're trying to look for fluorescein stain with that ambient normal fluorescent lighting, we miss some ulcers, or you can't really tell the depth or the severity of the lesion. So going into a dark room is definitely an advantage to help people when we're diagnosing a corneal ulcer. So for our next quiz, we're going to kind of look at the severity, actually be the next 3 quizzes. So I kind of want you to look at these eyes and tell me which one of these has the worst ulcer. I'm going to actually just get rid of this. Yeah, so that first one definitely is the worst ulcer here. That one has kind of some depth to the lesion. Here's our scoreboard. E here first, coming up hot, and Dr. K coming in second here, shifting around. But this ulcer here has, if you look at this, you can appreciate this is kind of the edge of that ulcer, and there's some depth here. This is very irregular across the surface. Some other things here that you would see is that, you know, pay attention to the entire eye. Down here at the bottom, we've got some hypopyon blood in it. So this eye is mega inflamed. That is a sign of pretty bad uveitis when they're accumulating white and red blood cells inside the eye. The other thing, as we look at this eye, this comes up, you can see these red lines here. That is a blood vessel growing in that indicates chronicity for this lesion. So there's, you know, this is not a new lesion. That tells me that this has been going on for a little bit of time because we've got some blood vessels coming in. So this is definitely the worst of those. The other 2 lesions on that quiz, those were actually pretty superficial ulcers. They didn't have much depth to them at all. And so this one definitely takes the cake as our worst one. Just a reminder here of what we're looking at when we do the fluorescein stain. So our cornea kind of has 3 big layers. We've got the epithelium on the outside, the big stroma, which makes up the meat of the cornea, and then the inside layer that we kind of group together, the desmus membrane and endothelium. So when we put fluorescein on an eye, fluorescein doesn't stick to this outside layer. It does not stick to the epithelium, and it doesn't stick to this inside layer either. It only sticks to this middle layer. So when we have an ulcer, that essentially is telling us that this outside, the epithelial layer, is not intact. and it will stain anything here until we get down. If we had a lesion that went all the way down to Descemet's membrane, then we wouldn't have fluorescein stain in the bottom either. So that can help you kind of differentiate it. You know, when you think it's deep, you can see a crater. Is there fluorescein in the bottom or is there not? Kind of helps you with the severity level of the ulcer. So here's another ulcer here, kind of asking what depth you think that this ulcer is. So that will help us to determine the severity of this. Racking in ulcers, or racking in answers. Couple more seconds left. Any last minute answers? Yes, so most people got that right. This was a superficial ulcer. So this ulcer here, this is what we call an indolent ulcer or a SCED. Here's our scoreboard. E, again, taking the leaderboard. Charlotte coming in second, and then Dr. K coming in third. But again, this ulcer, it is a superficial ulcer. It is, you don't see any depth to this lesion. You can kind of see that there's a little bit of a change in the severity or intensity of that fluorescein stain. And that is because this dog actually has an epithelial lip. This is, you know, that's kind of a buzzword in ophthalmology, this epithelial lip. That is what we indicate as needing to be debrided. So you can kind of see that there's a rim here of darker tissue in the middle, and then there's this more green, more fluorescent area around. And that's because the fluorescein stain in that area has actually leaked under the epithelium, and it's staining. So this is all a lip around the edge, where this is what is the true ulcer in that area. Our next one here, so try and categorize this ulcer for you. This is a little bitty tiny one in diameter, but we're kind of looking at the depth of this one is really what's gonna set this apart from other ulcers. Yeah, great. So most everybody got this one right too. It is a stromal ulcer. It is not quite a desmetocele, but it is, I would give this, just kind of off the top of my head, I would say maybe this is about 30% depth. I'd really have to put a slit lamp on it to know the true depth of this. But yeah, this is a melting stromal ulcer. So it is down into the stroma. Our scoreboard here. So again, this is, you know, there's a little bit of depth here. Some other things that we've got going on is that these ulcers, or the vessels, are coming out. This is definitely a chronic ulcer. These blood vessels, just as a general rule of thumb, take about a week to get started to even cross from the conjunctiva into the cornea. And then they only grow about 1 millimeter a day. So if we say 7 days to cross the limbus, and then a millimeter each day, so 8, 9, 10, 11, 12, you know, this ulcer didn't just happen. This has been there approximately 12 days on this dog. Proper treatment for this dog, we need to treat this very aggressively so that this doesn't continue to melt. So using a good broad spectrum topical antibiotic. Most of my cultures here at this clinic come back where they're sensitive to ofloxacin or neopolygram. Is a good kind of starting place for them. Some of the more resistant bugs need a little different specified antibiotic, but those are pretty good to start with. Definitely using serum on this. There is a new product on the market that is, it is an amnion. So we use this, it's a lyophilized amnion that we can use. If anybody thinks they need to use that, you can certainly come and talk to me, because that sounds like it's a pretty deep ulcer that may need optos help anyways. But then also our pain meds and oral doxy help with those melting ulcers. So we should have one more quiz here looking at severity of ulcer. Let's see how deep this one is. This actually did not have any fluorescein stain, but looking at this ulcer, I think there's some giving clues here on what we might be dealing with here. So let's see how we did. Yes, so this is indeed a desmetocele. So this cornea, the big thing here, you can see this is the lesion that we are most concerned about on this cornea, although there's a lot of other things happening. But as you can see, there's some depth here, and then down in the bottom, this big dark window that is right down to Desm's membrane at the very bottom. This is a very fragile eye. See how we did on that, how things changed. Oh, we got E coming in, 5 answers in a row. Charlotte and then Dr. K kicking up. Okay, this dog has anisocoria, so true or false? So, Optho has a pretty crazy lexicon. I'm pretty sure somebody just made up all these words along the way to throw into ophthalmology just to make it a more of a mysterious part of veterinary medicine. But here is, got one more answer, anybody? Okay, so most everybody got this right. This dog does have anisocoria. Anisocoria means difference in the pupils. So between the right eye and the left eye, you can see that when we shine a light at this dog, that the tapetal reflex, which is this yellow glow that comes through the pupil, this left pupil is quite large, and this right pupil is a lot smaller. So what that indicates is that this right eye, I mean, there's some other things going on here too, right? There's fluorescein stain here. There's this big blood clot inside the eye. But this anisocoria indicates that this dog has some pretty significant uveitis. So anisocoria is very helpful for me, or for anybody to help evaluate the level of uveitis that might be present just in one eye. I think a lot of times people get wrapped up in ophthalmology and they say it's an eye problem. I don't want to deal with it. But if we're stuck and our back's against the wall and you need to figure something out, remember that there is often a normal eye on the other side of the dog. So if you're trying to say if this eye has uveitis, doing this easy test, take them in a darkened room, let the pupils dilate as big as they're going to get, and then shine a light from a distance and you can see that tapetal reflex. It really gives you an idea of the pupil size and you can compare side to side. So that's very helpful, very inexpensive test. All you need is a light source. Scoreboard here. Ooh, Charlotte came up to the top, kicked E out. Nikki coming up. All right, fun. Scoreboard's changing. This is back to our desmetocele. So this, just to talk a little bit more about this eye, because there's a lot of lesions going on here. So we've got this brown pigment, not necessarily a problem, but what I am most concerned about here is this desmetocele, as we just talked about a little bit ago. And then, these blood vessels, these are all coming out. And then the other thing that's going on here is this diffuse dark kind of cloudy blue. This is edema. So this eye is very diseased, very chronic disease. And now we have this majorly deep ulcer right in the middle. These can be treated medically. So treat them as though they're a melting ulcer, maybe about 50% success rate. The big deal is that if medical treatment doesn't work, they often will rupture. So a ruptured eye is very painful, can lead to loss of vision and need to remove the eye. So we do recommend grafting in cases when they get this deep. And this is an example of what a conjunctival graft would look like on this dog. So these grafts are very successful, well over 85% success. It does unfortunately leave a big scar in the area where this adheres to. And you can see this tiny little suture here. This is all 9-aught Vicryl in the cornea. You can see these tiny little sutures, but bringing this graft out gives that immediate blood supply and tectonic support for this eye to heal well. Right. So this is a multiple answer question. So you can choose all of the answers that you think fit this eye. Okay, so definitely corneal melting was present, uveitis was present. That was evidenced by that hypopyon down in the bottom. So hypopyon is definitely a right answer. There was no fibrin in this eye per se, although I guess you could argue that's a histological diagnosis, but that yellow goo in the bottom of the eye was hypopyon. So this is all hypopyon. Generally, fibrin is stuck to the back of the eye or back of the ulcer when it is present in a bad melting ulcer like this. This eye has actually not ruptured yet. So this was all just melting. This is melting cornea that is on the surface of this eye. And then this one, ciliary flush, is not a super common term that's thrown around in general practice, but to me, what this means is that you can kind of see this red rim around the eye, that there is blood vessels kind of crossing the limbus 360 degrees that are coming in, and that is called ciliary flush, and that indicates very severe uveitis that is just creating this ridiculously strong inflammatory response where the eye is just, or the body is sending out the army to try and treat this really bad inflammation of this ulcer. So nice, you guys got a lot of these answers for this eye. We're gonna do another one after we get our scoreboards totaled up. So again, pick all of the correct answers that you think fit the eye. All right, so this eye, this is a little bit of a tricky one. So
You love that? Yeah. Thanks.
somebody have a question?
Oh, I don't know. Off the top of the head.
So maybe not. So this eye, what has happened here, this little dog got in a fight with a cat, and this cat sliced open the cornea right here. This is actually iris that is protruding through this eye, and that iris is very angry and inflamed. There's like a blood layer across the top of the iris there. We've got corneal edema adjacent to that. The eye, there's some mucoid discharge here, small pupil indicating uveitis. So there is not melting present here. This was kind of a tricky one, but there is no melting. This is a very acute process. If we let this go, it probably would start to melt, but it is just in the acute process here that it hasn't really had a chance to do that yet. So no melting yet. There is a corneal perforation. This is not a foreign body. This is actually iris prolapse. And then he's got some corneal edema. Hypopyon is not present. He hasn't had a time to develop that yet, but given time, he certainly would. So treatment for this dog is definitely refer to ophtho, and we would get him under the operating microscope, shove this iris in if it's still healthy. Otherwise, we sometimes need to amputate that part of the iris. And then we would sew up this hole. And usually, these cat scratches, they're nice. Cats are good surgeons. They make nice little straight lines often that are easy to sew up. So we did pretty well on these. But we did get a little tricked about the foreign body. There was not a foreign body. That was actually her own iris sticking through. How'd we do on the scoreboard? Okay. All right, this is a kitty cat disease, so that should give a little tip off of what's happening here. Try and get that. Kind of a gnarly looking kitty cat eye. This is not an acute process. This definitely takes some time. It can come after a long while. So this is actually eosinophilic keratoconjunctivitis. We call it EK for short. These are actually eosinophilic plaques that have built up on the cornea. So this is kind of considered an immune mediated disease where they start putting eosinophils where they don't belong on the surface of their eye. It can include their cornea or their conjunctival surface, including the third eyelid. So it could be on the third eyelid, could be on the conjunctiva up here. This kitty was isolated to her conjunctiva in this photo. It did extend a little bit into the, I'm sorry, it was isolated on the cornea in the photo, and it did extend up into the conjunctiva a little bit up here where you can't see. But this is solely a kitty cat disease. It is very easily controlled with the right kind of drops. You can treat them with steroid drops, as well as a drug called majestrol acetate. That is a type of a hormonal drop, kind of in the steroid family. Here's our scoreboard. To diagnose this disease, we look for eosinophils. And so doing a corneal cytology is something that a lot of people, I mean, it's kind of freaky, right, to be touching the eye, but this is what you would see when you roll out a cytology on a slide under the microscope. And even if this was the only field you saw, this would be diagnostic for eosinophilic keratitis. So let's put your pin on the eosinophil. Yay! So majority of you were able to find the eosinophil. Eosinophils are similar to what you would see in peripheral blood. For a cat, they tend to be extremely eosinophilic and have a little bit larger granules than what we see in peripheral blood. But this is an eosinophil on this kitty. These are keratocytes or epithelial cells from the cornea. And then this is an old degenerate neutrophil that's kind of fallen apart. And this is a neutrophil that is on its way to degenerating as well. So very good. Most of you got the eosinophil there. This is how you would take a corneal cytology. So numb the eye with proparacaine. These little cyto brushes, we have them in ophthalmology in our drawers here in 16 and 17. And this, you just need to very gently touch the cornea. Ideally, you would touch the area of interest, and then you would just roll it out onto a slide, just like you would like from a Q-tip cytology, except for these little bristles are very grabby. They do a great job of getting those cells without much pressure on the eye. We roll it out on the slide, allow it to dry, and then you can take a look, and you would hopefully see cells that were laid out just like that last one. This, why don't you get out of my way?
And Dr. Zimmer, we did have a question. Is EK painful?
It is not super painful, although blinking a little bit is one of the presenting signs, but usually clients will complain just about the eye looking different. And I think the cats are a little bit irritated, but I wouldn't say it's a super painful disease compared to like a routine corneal ulcer. They don't seem to be as painful. Caroline, I'm realizing my bar is at the top of the screen here. I don't know if everybody else is seeing that or if it's interfering with people's ability to see the questions.
It's still legible.
Okay. So I don't know how to get rid of that. Heidi drawing. Okay, so this was kind of a little bit of a tricky question, but the idea was that as we're sending medications home for clients, I want people to be thinking about the order that we apply medications to the eye. Okay, so in general, we will apply drops before ointments. Let me just get to this next slide here. In general, we apply drops before ointments, and so the kind of the thickness of the medication makes a difference. We want the drop to get on there to be able to penetrate the cornea, get in and do what it needs to do before the next thicker medication gets put on. The other thing that I recently learned at our annual conference this year is that the serum, so serum has protein in it, and that can actually interfere and bind with the antibiotics that we've already put on the eye. So definitely we don't want to put serum in before we put antibiotics, because if there's any residual serum, it could bind that antibiotic. So what was recommended at our ACVO conference is that we always put on the antibiotic and then wait at least 5 minutes before we do the serum, doing that next. And that will decrease our chance of the antibiotic binding to those proteins that could interfere with its ability to do its jobs. And then as we do ointments, we would always want to do those last. So kind of wait, ideally in a perfect world, we'd wait at least 10 minutes and then do the ointments after. But I realize it's not always a perfect world. And I still, even today, I had a cataract patient come back, and I mean, we're 7 weeks after surgery. And today he just realized, oh, you can't put the drops in at the same time. You actually have to wait and space them out. So I understand it's not perfect, and it's very difficult when we've got many patients hospitalized here, and and I've got these melting ulcers in the hospital. I'm saying, do drops every hour, and it's difficult to go back in every 5 minutes. We'd rather just put all the drops in at once, but it certainly makes a difference for their clinical outcome if we can do them in the proper order, as well as wait the proper amount of time in between the medications so that they can do their job. And then again, just as a reminder, we never want to use steroids on an ulcer. I know that's probably one of the things that we learned first for an ulcer, but just wanted to remind you that we don't put steroids on them. All right, here's another kitty cat only disease. So looking for what we might think is the problem. Yay, overwhelming. This is great. So this eye certainly has a big sequestrum here. This is the problem in this eye, this big black necrotic area on the cornea. It is not actually melting, although it does. There is a little bit of this could potentially be construed as looking kind of melty and mushy on the cornea. It actually was not when you looked at it in person. These 2D photos make eye evaluations difficult, but this is a giant piece of necrotic tissue. See how we did on that, how the scoreboard changed? Not much. All right, keeping steady. All right, so kitties, yes, this is thought to be due to chronic inflammation. So their, herpes is probably our #1 that's associated with this, but also other things, chlamydia, mycoplasma, calicivirus. We've got all these other infectious things that can also be a problem. One of the bigger things that can lead to this is also chronic mechanical problems. So things like entropion, where that lower eyelid will roll in, especially on the inside corner. This is a little bit of a breed predisposition too. We see our brachycephalic cats having more common sequestrum. So our Hemis and Persians, some of the short hairs will get these, and that's thought to be because they often have a little bit of like medial entropion, and then also they have a less of a blink rate than other cats that are normal, kind of the normal anatomy cats with the smaller palpebral fissures. They tend to blink more often and have better corneal sensation. So the kitties with the big prominent eyes, unfortunately, tend to get more of these. Just a little bit more description of what's happening in this photo. The sequestrum's been there for a while, and that is evidenced by these long blood vessels that are coming in. In the background of this eye, you can faintly make out the edge of the pupil here. So I know sequestrum, some people are like thinking that this is a black pupil in the eye. In fact, they're not. This is the edge of the pupil there. So treatment for this, ideally, we would take this off surgically, put in a little sliding corneal conjunctival transposition, and those cats do great, but some cats are not anesthetic candidates, and some we just can't take to surgery for financial reasons. So what will often happen is that these blood vessels continue to grow in. They will grow under that sequestrum and actually make a little granulation tissue and kind of slough off that sequestrum. I've got quite a few kitties that I manage now where they'll come in every few months and I'll trim the edge of the sequestrum where it's been elevated. And so that sequestrum just kind of gets smaller and smaller, and eventually it just sloughs off, and then the blood vessels recede out of that area. So that is also an option. It can take months and months and months for that to happen, but there is a non-surgical option for kitties who can't go under the knife as well. Going back to our melting ulcer, if we were to take a cytology of this, so anybody who's feeling froggy and would actually want to touch that with a little cytology brush, what would you see on the slide? All right, so often, main thing we see, definitely neutrophils. We don't often see eosinophils. They can be an occasional occasionally invited to a melting ulcer, but they are not super common. We will often see those keratocytes or epithelial cells, and then bacteria doesn't have to be there, but it often is. So this is what we would see often on a melting ulcer. We've got some chains of cocci in the background. These look like they were intracellular, and the cell is kind of degenerating here in this neutrophil. But look at all these degenerate neutrophils here in the background. This may have been a macrophage, which is an occasional also invited, but not very often do they show up. I don't see any lymphocytes in this, but they will show up sometimes too. And then we do see cocci or rods, and that can help me change my antibiotic spectrum of what we want to do right off the bat. If we see cocci, our most common offenders are like a staph or a strep, and then the rods tend to be Pseudomonas when they show up in the eye. Those are kind of our big offenders that cause like melting ulcers. So I think that is the end of my presentation. This should here give us an idea of who was our winner. Here we are in third place, Dr. K. Estrella, I think that might be Estrella as number 2, and then it looks like Charlotte got number 1, and that is great. And we've got Katie and Nikki as runners up. I do have to say that Charlotte and my team has already seen this presentation. I did make some edits since they saw it, so I'm not sure that they can actually win the prize. So if this E is Estrella, that means that Dr. K is our winner. Otherwise, whoever is E, if they want to come to me, we can talk about the prize. I see that there's some questions, but I don't, looks like everything has been answered. Does anybody have any other questions? You're free to unmute yourself and ask questions. If not, then I think we are all set to, oh, is that a question?
No, that was just an attendee stepping out. Looks like we got one from Kara Perry though. Might be a silly one, but where are you getting the tissue to graft an eye?
Yeah, so that's a good question. So that conjunctiva that you saw in that photo, that was actually harvested from the top of the eye. So when I harvest those grafts, I actually harvest a pedicle. So I leave it attached at one end, and then I go and attach, or I harvest kind of like a little finger of tissue that, and then I can rotate it. So essentially it's like a rotational skin graft, but it's just of the conjunctiva, and I rotate that down and suture it over the hole in the eye. So it brings its own blood supply. You're welcome. Anything else? Okay, I think that's it. Everybody, thanks for playing along, and I will follow up with our scoreboard winners and go from there. Thanks, guys. Have a great day.
Thanks, Dr. Zimmer.
You're welcome.